that this is what I have learned from here. So how can I teach? But that's Arisa articles. I'm sure there are more are joining. No problem. I think there will be a limit, but that's okay. Somebody admit. I admit somebody. Admit Ammar Bashir. Sorry.
Will the man send the link to them? Ask him to send the link to them. Come on, guys.
It's okay. When do we have to finish? That's the most important thing.
No problem. It's usually 9, but it's okay.
So the reason we chose both the residents and I both agreed for hemostasis is that going back to my time in training when I was in your schools, the bosses only say one thing you need to master was hemostasis. And once you master hemostasis and tissue respect, all the things that has come now, shall we start now? We have got 6.
Well, everybody else. What happened to the beat? Artics. Amar, you're so slow. As I'm on. So in the meantime, lead will cause serious problem to the patient.
So there are only 2 types of surgeons, as my teacher used to say, some who coagulate and cut, and some who cut and coagulate. Which one is better? Thank you. So I start now. Shall we? Welcome.
Yeah.
Do you want to play code?
You want to play?
Good. Thank you. Sorry, I don't know everybody's name, but if I come again one more time, I'll know everybody by name. It will be bad for you because then I will be calling you by name. So it's better today that it is random. Okay. So we start. I think it may reach a limit. So we're starting. This may be very basic. This was a talk given in Wellington in June. So I recycle a lot. What is the weight of our brain? I know this is very basic because it was actually meant for the talk is for trainees, but this was for nurses, the kids. So 3 people got it right. Okay. Next.
Human brain without theory.
Okay. Next.
0.
What is the diameter of spinal cord? It is just to warm up. It may not have direct bearing of the two. Well done.
What happened? Nobody else is playing.
Okay, well, it gives 15 seconds. And one of the things I have learned in code is that it's not only the correct answer, it is the speed with which you get. Next one.
Your friend is joining. It is correct. He's entered. Welcome.
Good morning, Arshad.
Good morning.
Jai Shri Krishna.
Professor, how are you?
Even better after talking to you. I was just saying to Professor Sarif that you have already greeted me in the morning. Thank you.
Yes.
Thank you.
Good morning, Professor Salman.
Good morning. Good to hear from you.
Good to hear you.
Ladies. We are having a little quiz. I'm
Wow.
sure you know that all.
Okay.
Good. All these are famous surgeons. Two are no more. We only lost Professor Yazhargin in June. So I'm sure those who are very observant viewers in Malis, bipolar Malis. So there are Malis who used to work in Mount Sinai in New York. And I think Arctics is winning. And let's see.
That's so bad.
Last one. Physical, I think this is the last one. Physical pressure is the best way. Physical pressure is the best way for hemostasis in neurosurgery. True or false? Let me just move this one. So I think it is very appropriate that we have chosen the correct topic. But we have established that everybody thought that physical pressure is the best way. And because brain and spinal cord and the nerves are very soft, we can't apply. So this is the right thing. So I'm happy that we have chosen the right topic. Now let's see. Let's see the score. Uh, Podium. Kubra. Well done. Second runner up. Arisha, runners up. And Arctics. Sorry, the music is not playing. My apologies. I should have kept it on. Okay. Thank you. So now we can come out of this. I stop sharing this, and then I will bring up the. Sorry, you can't see me much. I'm in dark, but that's okay. Let me see if I can. Now I have to go back to the presentations. I hope, can you believe I have Achi? And we are talking about the hemostasis. Very soon we can stop the music now. Now, how do I? No. I mean, how do I stop the music? That's the question. Yeah. The presentation is already. Thank you. Okay, thank you. So, causes of bleeding, we already know that, of course, every live tissue bleeds, and some people also said every bleeding eventually stops. I would agree in many respects that if patient stops pumping the heart, it will stop. But we don't want to reach that stage. I am worried about the bleeding from the bone, especially in spine. If we have done a major decompression, then the bleeding from the spine, the end of the spinous process that we have nibbled off, or some of the lamina and the lateral masses and facets, that bleeding, unless you have taken care, will not stop, and it will be minor ooze and can lead to hematoma, etc. So, of course, there are some bleeding disorders, there are some acquired disorders, congenital or acquired, and then drug related in the modern day, as we discussed the other day, because of the increasing aging population and because they have got lots of comorbidities and they are on anticoagulant and antiplatelet medication, they can be having a bleeding. And of course, there is something that happens in head injury. I have had this experience at a very uh, significantly experienced level. Maybe around 10 years ago, I did in the middle of the night with no resident around an acute subdural hematoma, and I was very proud that I was trying to demonstrate what is the most ideal way to do a subdural hematoma. And to my surprise, as I was closing, patient started bleeding and bleeding and bleeding. And do you know why? Sometimes in very severe head injuries with contusions, especially, patients can bleed. There are some factors which are released, which patient goes into what is known as dehiscence.
Government-induced coagulopathy.
Yes, 100 marks. Well done. I was looking for the word. Trauma-induced coagulopathy. Yes. So I was trying to blame the anesthetist, but to be very honest, the anesthetist came with the right suggestion to this that this is traumatic coagulopathy, and we have to replace with the appropriate. So the causes of bleeding could be many. Uh, The methods of coagulation are mechanical, thermocoagulation, which is what we are most used to, and chemical, which is what we never had, but now in the modern generation, you have lots of chemical. I don't know whether you ever had what we used to call ferracrilum, which was a snake venom. This was in 90s that we got some snake venom to help. It used to be called ferracrilum. I am sure Arshad may remember that. So we used to use ferracrilum, which was a snake venom, which we used to
Never seen.
topical. But otherwise, the chemicals are in the modern generation in the last 25 years. But we grew up with thermocoagulation, and we already talked about this. Now, how many of you know? We remember last time we talked about Dandy, and we said that Dandy has lots of contributions to neurosurgery. Has anybody seen this forceps? So the design here is it is curved on edge. So normally mosquito or artery forceps are like that. This is like that. So the curve on the edge and how we used to use, and this is what I grew up with. So this is how we used to apply that, and we only used to catch the Gallia aponeurotica. We don't have to catch every single bleeding vessel, and then after 4 or 5 we will apply a rubber band. And the reason we wanted that curved edge was that it falls away from the operative space. So that is how we grew up. We because we didn't have these Randy clips that you have subsequently got. So in your days, it was rainy clips, and again, I'm sure you must have used metallic rainy clips to start with, which we used to re-sterilize. But in modern days, you have got plastic disposable, and some of you may even have seen automatic loaded gun that you can keep applying. So Rennie clips is what is currently used, and these are the ways of physical force we are talking about. So this is the only exception in neurosurgery. Physical force is used as a hemostasis. It is fast and easily applicable, and as I said, they are having. And again, you don't have to apply it at the every breeding point. You only apply between the Gallia aponeurotica and the scalp, and It is very easy. Some people apply gauze around skin to protect, especially young babies, but otherwise not. Now, bone wax. Sir Victor Horsley. In fact, some people consider that Victor Horsley was a neurosurgeon even before Harvey Cushing. And Britishers are very proud. And the only similarity between him and me is that he also used to have the mustache with side curves up. So in his honor, I have kept it like that today. So the original composition was beeswax, almond oil, and salicylic acid. Now the modern wax has refined beeswax and isopropyl palmiate. It is effective on bleeding from bone. Now, one of the things, if you are asked in examination, what is the purpose or what is the use of the bone wax? It is not only to stop bleeding from the bone, which is what we use. But the most important thing is that we should not leave a lot of bone wax behind, because we have seen sometimes infections as a foreign material there, and sometimes it can also, in especially spine, very narrow, very small opening, it can cause space occupation. But the most important thing is that in cranium, especially if there is a very large diploid, and we are in a head high position, then it can also be a source of venous air embolism. And therefore, one of the most important advantage of bone wax is if you smear the bone edges and stop this deploy venous channels to absorb air, then you can prevent air embolism. So that's one of the important things. Now, muscle, again, when we didn't have the modern gadgets like all the chemical hemostatic agents, this used to be very good. So if we have a premature rupture and while we are waiting for something else to happen, one of the things we used to do is to take a piece of temporalis, crush it, and that will release the good tissue thromboplastin when we didn't have the artificial tissue thromboplastin that we easily have. And this used to be very important and easy. And it was Harvey Cushing who gave us the first idea about using the muscle, and this is even regularly now can be used. Sometimes I have used it, especially in aneurysmal rupture, a muscle patch. If it is very close to the neck, then sometimes that is useful. The physical cotton balls and linen patties, but that's not to apply too much of pressure. But sometimes cotton woolly ball in a big tumor cavity with lots of saline irrigation can create enough weight for small peripheral minor oozing points to coagulate. Do you use hydrogen peroxide here? You know, in UK it is not allowed anymore. So we think hydrogen peroxide was our best friend, and we all have grown up with that. But nowadays we are not. So it is only, remember, this is another exception, that we use linen patches and cotton balls with gentle pressure. Now another thing. So I was mentioning that the first fundamental principle we all learned in neurosurgery before all the fancy techniques and subspecialty fellowships and all God knows what. Nowadays there are 7 or 8 subspecialties that you all eventually progress to, was hemostasis and tissue respect. So we were never allowed to touch any nervous tissue with any instrument directly. There is always a linen patty between the instrument and the nervous tissue. So again, tissue respect, and here physical pressure with the cotton balls, or now metal clips. Now again, very rarely you might have seen this. Silver clips used to be very common. Again, this used to be reusable, and it used to be on a metal tray where we had to pick up each one. And when is the best place for using the metal clip? Anyone? Well done, sinuses, yes. So especially when you are opening the posterior fossa dura, and if you are thinking of this occipital sinus or circular sinus, where is circular sinus? Yes, so at the foramen magnum is a circular sinus. So that's where you apply the silver clip and cut between those two. So neural venous sinuses. See, most of the answers are there. As I said, that I asked lots of questions, but most of the answers are there. Just you have to be present with your mind. And these are the 4 now modern gadgets are again available, that you have got this ready-made loaded gun applicator, or you can have these various sizes of the clips available. Electrocoagulation. This was someone's thought, and who was the trainer who trained Harvey Cushing? You know, anybody has done general surgery? Anybody has done general surgery? All have done. So, who have done some in breast surgery? I know breast surgery classification has changed, but there used to be called. Sorry. There used to be called various types of mastectomy, radical mastectomy, modified radical mastectomy. There was a name attached to that. There was one Valder. So actually, Halsted was the teacher to Halve Cushing, and he was influential in so electrocoagulation. There are various things, and in fact, in the poor olden days, people have used a very hot rod to control the bleeding, but that is in Hippocrates' day, the hot iron rod. But then we go all this historical aspect. By the way, I was discussed with Professor Sarif, and in some way, I'm happy to share all these slides later on my email if that is of any use. Um, Anybody knows who was William McEwan? Sir William McEwan was a neurosurgeon in Glasgow, and it is said he practiced in pre-antibiotic and pre-imaging era. So when there were not so many sophisticated antibiotics and not so much of imaging, pre-CT era and pre-penicillin era. And it is said that his results of brain abscess are still not equal to match our current with all the sophisticated imaging we have and all the sophisticated antibiotics we have. So Cushing gave William McEwan a memorial lecture in 1927, and he mentioned about electrocoagulation then first time. And Bowie, sometimes we also say monopolar cautery, Bowie cautery. So that Bowie is and then there is a Doyen retractor. So the cautery has these two functions, you know, yellow and blue. Blue is coagulation and yellow is cutting. And this is how. So in cutting, because the energy is very high, the cell is coagulated and dehydration by heating. And if it is intense energy, then cell is exploded, and that's how we cut. So in the yellow, the energy is very high, and therefore cell explodes and we cut the tissue. But in blue, there is a coagulation because there is a dehydration by heating. Monopolar, the contraindications are you can't use monopolar in with defibrillator, implants, and flammables. So we can't use alcoholic solutions or unless they are used and dried. Make sure that and of course, we should also exercise caution on bony prominences, on scars, and in metallic implants. It was very late in my career, but one of the best advantage of monopolar I have found is on the revision shunts, because you can't work with a monopolar on the plastic tubing and it will not cut. So when there's a lot of scar and you are trying to explore the previous shunt tubing, using a monopolar of that is very useful, provided there is no metal implant or there is no metal component and you can't use it in the programmable valve that we normally have. Am I making sense? I think we are done halfway. Okay, sir, carry on. Sure. So bipolar, malice. So remember this sort of figure, you will see malice, and there are lots of advantages. The difference between monopolar and bipolar, I'm sure you know, that monopolar, the current only goes between the 2 points of the bipolar forceps. So there is very little charring and destruction of the tissue around, while in monopolar, there is the earthing plate, so the current passes through the whole body, and therefore there is lots of charring. So by and large, we do not use monopolar after we finish with the uh, scalp or skin and subcutaneous tissue and fascia in spine. Sometimes we split muscles. I worked with a trainee from Greece who would never use monopolar in muscles because sometimes they say that healing is poor the wounds are more painful, so they only use knife, the clean cut, even in the muscles eating part. But bipolar is very good. And another thing I insist that the better you become a surgeon, the lowest current you will be using of bipolar. So if you are not sure, if I have to kill my enemy, how many bullets I need? Thank you, well done, 100 marks. Because I should be sharpshooter, but I only need one bullet. If I need more than one, that is shooter. So say the bipolar, the lowest setting you can use, that means you know exactly where the bleeding is from. When you do not know where the bleeding, then you keep asking the nurses, can you increase the bipolar? That means you do not know where the bleeding point is. So the success is that to absolutely isolate where the bleeding point is, patty, suction. So we never had these two queers that you have nowadays to put. Arshad may agree that in our time we didn't have this plastic or metal or two queers to put the bipolar and the suction. Our hands were to hold when boss was operating, he will do this, and that means I will hold the suction and I will hold the cautery, and then whenever boss wants, I will give it. So what I'm trying to say is that suction and bipolar are the only two things you need for most of the neurosurgery. So enough about Malish. Very great surgeon from Mount Sinai in New York. Thermal, it enhances platelet aggregation, release clotting factors, loses effect in severe thrombocytopenia. So this will be very useful when we come towards the end, which is what the modern companies try to promote, that there are types of hemostasis which are called active and passive. And some passive hemostats, which most of us use in day-to-day life, are only going to control some bleeding, but if someone has got an underlying coagulation disorder, then those will not work, and that's when we need to use. And of course, sometimes what I call therapeutic cheating, and also when I'm working with junior, I say that not to be used without parental supervision, which is what I have learned from my boss, is what I call therapeutic cheating is when I was talking about the bleeding from the bone edges in the spine, when the chopped spinous process or the lamina is sometimes you can use the monopolar on bone because that means you don't leave too much of bone wax, no foreign body, and by and large you can control minor rules from that. The topical now, the modern generation that you are all trained with is we are talking about its safety, efficacy, usability, cost, and availability. So, of course, cost is an important factor in low and middle income countries. But I know that most of the people, life is more important than cost, so we don't get. And we talked about the gelatin sponge, which I grew up with. Now, one of the companies, this Ethicon Johnson and Johnson, tells me that the most ideal hemostatic substance for neurosurgery is this microfibrillar collagen, what we call um, Surgicel fibrillar. I don't know whether do you use
We do have.
yeah. So I have gone from using the mesh Surgicel, which we occasionally lay on the dura. By and large, I use microfibrillar collagen and of course oxidized cellulose. We were talking about the oxycell we have.
Sell it 4 times costly.
Maybe that's why they are trying to promote.
Before we carry on, shall we get some breakfast, please?
No. I had something. Please, this is
Are
breakfast.
you sure you
Yes,
had breakfast?
absolutely. Thank you for
You did
asking.
not have breakfast.
No. Honestly, I did. In fact, I have got some stock here as well. Thank you for offer though. Thank you for offer. So gelatin sponge has been going on since 1940s, and for gelatin, one of the I know there may be less. I know that there is another angle to your practice is that halal product, and you may want to think of that. But one a good friend of mine, Ravi Nanapanani from Cardiff, actually did a study on consenting patients, and we talk about in some cases in UK practice Jehovah's Witness, and we ask about blood and blood products. But we normally don't ask about whether the products we are using has any animal. For example, if I'm strict vegetarian, would I have an objection to using any products that have like pork gelatin in that? So that is what we should also think of. And same thing in your practice, whether halal is.
Would you have it?
Uh, I would not.
Really?
Yeah. Now, the question is, which I don't have an answer, is in what situation, whether you say you are clipping my aneurysm and if there's a life and death, would I still have? I am not sure. I don't have the answer. But I know from other criticism point of view that Mahatma Gandhi did not want something for his wife when she was ill, but he did use it for himself. So there could be controversial. But the most important thing is that it absorbs 45 times its weight and expands up to 200 times. So the most important thing is that, again, if you are trying to put this in the neural foramen, I have seen people waking up with the foot drop because of the compression of the nerve. I also had in another example, which I will quote later on, a patient following a simple lumbar microdiscectomy has woken up with a chorda equina, but for that was another reason. So this cannot be used again with cell salvage. I don't know whether you use cell salvage or not, but in many procedures where there is no malignancy concern, especially if you are doing major fusion or scoliosis correction, many times we use cell salvage, but this cannot be used because of its size of the filters that we can't. Microfibrillated collagen is derived from bovine skin, minimal swelling, matrix, etc. It loses again in the thrombocytopenia, and we'll come later on what we can use in that situation and could be used on bone even. So this can be used on bone. So again, the fibrillar I was mentioning about that can be used. The oxidized cellulose is what I grew up with. It is the polymer and regenerated into continuous fiber knitted gauze oxidized. This is what I used to have, the mass that we used to use. It absorbed within 4 to 8 weeks. It is also acidic and therefore in theory it is bactericidal. So there is a question that if there is an infection and a bleeding, should we leave any foreign material or not? But there is a claim that this has got acidic base and therefore it is bactericidal and therefore it can be still used. It may retard bone growth. So again, those who are strong biomechanical background or orthopedic background will not use it when they are doing a major fusion procedures because it will retard the bone growth. And it also interferes with epithelialization. Flowables, now this is the modern generation, and I'll tell you later on in a minute. So it has got a possibility of cerebral edema, and one of the things I learned when we were first taken by the company to its course that Laligam Shekhar possibly reported a case that somebody had injected into the sinus, and that led to sinus thrombosis. So we must make sure that we don't inject this into the sinus, no matter how much is the bleeding, because
There's a
those.
recommendation to do cavernous sinus surgery.
Yeah.
That's how they do the cavernous sinus surgery in US at the moment.
Yes, but cavernous sinus again is a misnomer because it is not actually a sinus like the superior sagittal sinus or a.
Oh, yeah.
Yeah, so that's why. So two things, flow seal, which is from the Baxter and the Surgy flow, and I have no particular interest, but it has got, it is active hemostatic agent, and it can use again. So I bring back the cascade, the coagulation cascade, and the thrombin, which is very important. And the both the companies will market saying that some one is ready and someone has to be made, and this will take longer, 10 seconds and 30 seconds, and this and that. That is all to individual discretion. What is important is that I feel very unhappy that the in the morning theater brief when the juniors are saying that I am doing a microdiscectomy and these are the things I want, and they say, oh, by the way, also have the flow seal open, and my heart sinks. I mean, that means they have already decided that it is going to bleed, number one, and they are not going to be able to control it with normal means. And I say that whenever you use flow seal, I have to observe fast because that is, in my opinion, in my surgical hand technique, it's a disgrace. So, and this funny thing happened that when I give this talk, I give this talk every year to the boot camp in Coventry that Amar Saxena and they run. And Peter Whitfield, the president of the WFS, was there. And I said, Peter, do you use? And he said, yes. And I said, Peter, I actually observe fast if my trainees use it. So it was very funny. But I have also learned a mistake by my own practice that once I was superior sagittal sinus parasagittal meningioma, and patient bled and bled and bled. And I wish I had used, we could save the patient. The patient didn't come to any harm. But I think if I had not been so dogmatic about my surgical skill and used the flucil little earlier, perhaps we would have saved a couple of transfusions. So I have learned my mistake, and since then I have changed my practice also. So I don't observe fast now, but I still prefer not to have it open, only open when it is required rather than as a routine, because again there's a cost factor. And my own emphasis is actually a training that we all should be able to maintain the hemostasis and achieve the hemostasis by the conventional means, which is suction and bipolar coagulation. Fibril sealant, though they also, this is what we are talking about, the tissue and other glue, they also have hemostatic property. And I'm mentioning tusil and avicil, and they are, the components are there, and it also has some hemostatic property. The hydrogen peroxide is controversial. In UK, we can't use it. In New Zealand, we used to use it. I love it because it is a very, very useful. And the mechanism is obstruction of the microvasculature, removal of tissue, and vasoconstriction. And there is a claim that significant damage to surrounding brain and neural tissue. I will quote two examples. Once I was doing ACDF, and I'm very obsessed with hemostasis. I used to have a reputation that I catch RBCs. So even though I don't use drains, except subdural hematoma, I don't put drains. So I never put drain in the ACDF, which should be used when required. But because of the continuous ooze after doing everything, putting the cage, I put this hydrogen peroxide. And we were about to finish, and the researcher said, "What have you done, Pragnesh?" Because patient's blood pressure went into 200s and heart rate also very high. And what must have happened is that in the epidural space, with the decompression of the spine, it must have trickled right up to the brainstem area, and that must have triggered the brainstem reflexes. So with lots of saline irrigation and immediately opening up little more space, we could manage. So be careful when you are using hydrogen peroxide in closed cavities, especially if you have opened inadvertently the ventricle. Then one has to be very careful not to create lots of challenges. I do not have any experience of the laser. You might have had, because I think in Beaumont they used to use laser. I haven't had chance to use, so I am not going to talk. But as a trainee, for your exam purpose, you must know that ND-YAG is the one which is used in neurosurgery. Where in the I will give you a hint. Where in pediatric neurosurgery it is considered a good adjunct. Uh, that is fetal surgery. No, thank you for answer. Answer is slightly different. In the lipomyelomenigosin, they say that there is a very nice plane that you can develop with. And on that note, historical again, who has changed in the modern, in your generation, who has changed the concept of lipomyelomenigosin surgery? In my time, we thought that they are unoperable and we should not be operating unless they are symptomatic. From there was a controversy between Americans and British, or Europeans and British. And there is somebody who has changed, who is a game changer in lipomyelomenigosin surgery. I hope you know the classifications also. The transition, the dorsally ectophatic, and how many types of it? Coordinate transition. Do you know who has changed the game plan in the treatment of lipomyeloma? Declan Pang, who used to be practicing in California, now he's located to London and he works with the Great Ormond Street. He has taught world that we can excise the lipomas completely without any additional neurological action. So those who are interested can look at some of the articles of Declan Pang. Antiplatelets, again, we were talking about how long should we wait, and recently we have produced SBNS guidance on to how much we should wait for various things, and you can see various agents that we use, which factors they work on and for what could be the antidote and again the anticoagulant. So that was regarding the antiplatelets and now anticoagulant. So you must also know for exam all the modern they call doc or anticoagulants, which are those and how long we should wait for, and if need be there, what is the antidote. We usually work with anesthetist and the hematologist to guide us as to what, which is an easy way. But for exam, you have to know all the answers. And adjuncts. Now, this is where I was talking about that there are active and there are passive. So active will work in every situation, no matter how desperate it is. Patients have bleeding disorders and whatnot. The passive will not work in that situation. And the active are these flow seals and other things, and passive are the previous ones we discussed about, right from the gel foam, etc. There's a literature, so some of the papers that I have quoted, and this is very interesting. I don't know whether we use or not. We have lots of scales for various things, but this is very useful. That it is the only scale which is validated by, this is the scale of what bleeding. So I don't know whether you have the same situation here. We have in Britain again something called, if patient is bleeding torrentially, we have to ring the blood bank with a special word called massive hemorrhage protocol. That means they will supply n number of blood without asking again and again. I'm going to tell something lighter at the end of this. Remind me my own classification, but this is a vague classification. So it is there is a clear destination. So like we were talking about the Glasgow Coma scale, it is a common language that everybody understands. When you say GCS 15 or GCS 12, everybody knows what you are talking about. Or when you are accepting a reference from a peripheral hospital, if they tell you this, same way in the bleeding also, we need to have a common terminology to refer to, and there are various ways, and this has been studied with all the specialties, and these are the four grades. So grade 1 is the mild, and grade 4 is the life threatening, which is where we will be. So for example, if aneurysm has burst, then that would be life threatening, or an AVM, that will be the situation. I have my own classification of hemostasis, and I will also give you my original contribution to neurosurgery. Grade 1, the surgeon knows. So when surgeon is trembling, that means they know grade 1. It is something that they are not comfortable with. Grade 2, anesthetist knows because they start seeing the hypotension and tachycardia and all the things. Grade 3 is the blood bank knows because we are asking repeatedly blood, 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 blood. Grade 4 is the autopsy person knows. And grade 5 is the media knows. Next day you are in the newspaper that Mr. Bhatt killed somebody on table because of this and that. So this is my classification of the grading of the hemostasis. So this should be implemented routinely in our practice, and there is a way we can weigh the gauze before and after and then decide how much it is. And then this is another grade, spot grade, but Vibe grade is better because it has got excellent reproducibility. It is repeated by every surgeon and was looked at 11 different surgical specialties and 102 surgeons. Again, this has got some commercial. So Vibe scale is better than the sport scale I mentioned. And I have tried to implement this in our practice. So coming to the end, there are some products which are used for the active hemostasis, and there are some which are passive, like most of the things you use. Uh, the most important thing is, as my own professor again, Turel, who is master of the complications in neurosurgery conferences all over the world, and he is organizing, I'm sure you will be going to that in June in Italy. He says that it is easier to stay out of complications than to get out of the complication. And Einstein says that intellectuals solve the problems and geniuses prevent them. Thank you very much. The Any question?
Thank you.
Did it make sense?
Yes.
So the fundamental is, even if you have not understood any of these, hemostasis is the most important. And the more precise you are in locating it, the lower current you can use of bipolar. And there are certain situations with my own profession I am saying that fluoxetine or modern surgery flow are useful and dependent, and do not use it in every, because otherwise you will get addicted to use and your own hemostatic skill will get down and down and down. The other original contribution, like the my own grading of hemorrhage, is my rule. If INR is more than GCS, usually we don't have to do anything. That's my contribution to neurosurgery. Bhatt's rule. INR more than GCS, no neurosurgery. Thank you for.
Any questions? Bhatt is our consultant sitting next to me. Hello.
Thank you. You are most responsive, and you are, of course. Thank you.
Responsibility.
You help me to get this. Thank you. Shall we stop the sharing?
We want to thank people who were connected and say bye-bye.
Hello. Thank you very much for patient listening. I hope you could listen and I made some sense. Yeah, maybe halfway through. There are 4 people. Let me see who are they. LNH, Lukman Hadi, and Amnar Bashir. Thank you for those who attended and tolerated me, and thank you for those who had no choice. You could have at least muted and gone to do whatever you wanted, but you didn't have. Thank you very much. I'll log off.